Hello, everybody. Thank you for inviting me to make a lecture on my favorite topic is pelvic floor in female athletes and sportswomen. I just try to make a short summary of the pathophysiology before to have some word on the overview of therapeutic options. First of all, I would like to introduce me for people who didn't know yet who I'm. I'm a professor of physical therapy in charge of patients with problem of incontinence for many years. And since 20 years, I'm involved on the pelvic floor dysfunction for sportswomen. And I'm director of pelvic floor services in Paris to take care of these young nulliparous women for many years. You know that there are an increasing interest in physical activity sports worldwide, and we have a lot of women, very young, nulliparous, who are very embarrassed with this type of disorders, including pelvic floor dysfunction, urinary incontinence, stress, and overactive bladder. People are increasingly aware of a healthy lifestyle, and probably is one of the reasons of the interest for young women, nulliparous, or after delivery to be in good condition, to be fit, good shape, and probably that's the reason that we have so many women doing sports everywhere, specifically in the countries where we can do that. I was invited in 2004 to take care of this at UCLA, physical therapy department for sports. And very soon we were very surprising by the number of girls complaining of that, specifically with the risk factors of intra-abdominal pressure due to different sports. And we proposed a classification of that. And we had classified the sport in three groups. The first one is the high impact sports with team game like volleyball, handball, basketball. But we have some weightlifting, we have CrossFit. The second group is moderate pressure, and where the running, with aerobics, mountain biking, trekking, aquatic aerobics. And the last one is the low impact sports like walking, Nordic walking, swimming, scuba diving, kayaking, when we have no risk pressure on the pelvic floor. So in female athletes, physical activity may be a risk factor for urinary incontinence. The most common symptom are stress incontinence, a rarely overactive bladder. It is reported a large variety of sports, leading athletes to change or compromise their performance or risk to be embarrassed by that during the training or the competition. Regarding the problems associated with the pelvic floor, the most commonly is probably stress incontinence due to the high pressure on the pelvic floor. It's very rare to have pelvic organ prolapse. Since female athletes have become important participants of professional sport, a wide range of sport-related pathology needs to be taken account in consideration among them. Caribou, who is still specialized in this field, have proposed many years ago two hypotheses on that. The first one is training program could decrease the risk or reducing the symptoms due to decrease the levator ani hiatus. And second hypothesis is that general exercise overloads, stretch, and weaken the pelvic floor. Running is different approach. Most of the time, this is the women who are running for a long time, like marathon, and 20, 25, 30 of the no-professional female marathon runners are experiencing urinary incontinence. It's incredible the number of people complaining on that. But probably running is a different approach and is not due necessarily to the intra-abdominal pressure. It could be done with a combination of weakness of the pelvic floor and overactive bladder. What could we propose, like strategies and treatment for this type of women complaining of incontinence during physical activity and sports? Most of the time, we need to know that women doing sports have very bad command function of the pelvic floor. They most of the time have a big pressure and doing a Valsalva instead of a lifting up. 25% have at least improper contraction of the pelvic floor. When we ask the patient to contract the muscle, they are not doing a lift up, they are pushing down. So it is not necessary to understand that at that time we can have not good control of the muscles. So the first thing we have to do is to try to improve the function and to try to help her to have a isolation of the bladder of the pelvic floor, and not to use the other muscle like adductors, glutei, and specifically the abs. It's very bad. As soon as the participant and the patient is doing properly the contraction, what we can do is try to strengthen the muscle and not and to avoid to use the other muscle except the pelvic floor. And sometimes the pelvic floor could be helped by co-contraction of the abdominal at the same time. Second, what is very important is after you are strengthening the muscle, you need to know that it's not in the lying position, but is most of the time in the standing position, because the patient is doing some exercises and running and lifting and do balls. And this is the reason that if you are just trying to help them in the supine position, it's not enough for her. So the second step is to try to do in normal supine, normal standing position. And the best for that is try to integrate the pelvic floor, the diaphragm, and the core for these athletes and these patients. That is very important after you have done awareness of the control of the muscle, strengthening of the muscle. You have to use the core in order to have the better posture during the contraction and during the movement. Then you can use biofeedback therapy. Biofeedback therapy is important to isolate the muscle of the pelvic floor, and you need to have a surface electrode to select the improper muscle like the glutei, the adductors, and the abs muscle. And then you have a sensor, a vaginal sensor, in order to record the pelvic floor muscle activity. That's very important to use a biofeedback machine with a screen and different channels for record the EMG activity of the muscles. Of course, in our clinic, we have a specific program, what we call this AIM-AB program with telemetry. It is the sportswoman is asked to perform various physical activities in our clinic, very similar to their own practice, such as running, lifting, and we use different equipments and a video and EMG and a screen in order to show them how they can try to reduce the abdominal pressure when they are doing the pelvic floor, and at what time we have fatigue muscle of the pelvic floor, so we know exactly at what time they will reduce, or the training program for them. Sometimes the patient has so weak muscle that we are obliged to use electrical stimulation. And electrical stimulation, very common in Europe, is rare in the States, and very common with vaginal or probe. But in this specific group of most of the time nulliparous, we don't recommend to use a vaginal sensor. We prefer to have some new device with a short who stimulate outside, and it's more comfortable for the patient. We can have the magnetic chair sometimes, because we can use anything just to sit on the chair. It's not the same result probably than the vaginal stimulation, but it's more comfortable and more acceptable for the young nulliparous women. Of course, we need to have some devices to insert urethra, or we have cup, or we have a small pessary. when we can recommend the woman to use when she is training and she's running. And this is most comfortable if a device is very small, because we have some trouble with young women to do that, but it could help them. So to summarize, we have different approaches for treating the female young sportswomen. The pelvic floor muscle training is important. The biofeedback is the first line for assessment of what is the right contraction of the pelvic floor, because this patient is most of the time doing a Valsalva procedure when we have to leave. The telemetry, in order to train the muscle at the same time they are using the machine, their equipment, is good. Sometimes we have some mechanical devices, and very rare we are propose a surgery with sling for this group. We just propose this for women after childbirth, 1 year of treatment if they are coming back to make some training program, running, and do some high impact physical therapy, high impact sports without good result with the physical therapy. So it is very common now. A lot of women, very young, are complaining of incontinence, and it's very difficult to deal with these patients because they are not aware exactly as the pelvic floor, like pregnant women who after childbirth. They are very embarrassed by that. So we need, of course, the help of the coaches, the help of a gynecologist, in order to help these women to try to have a better life, and specifically if they are young, without any pregnancy, because we know that after pregnancy and childbirth, everything could be worsened. Thank you very much for listening.